today be talking about current evidence on ultrasound for shock management. My name is Erik Su. I'm a adult and pediatric cardiac intensivist at Texas Children's. We'll be talking about the current evidence on shock management and how POCUS is integrating into that care and how people are approaching this as it's an ongoing development in our current medical education and practice. I just have some disclosures. I do some CME courses, and we do run a course here as a disclosure to conflicts of interest pertaining to education. So just to start out, there's the question that I'd like to pose to everyone to just think about. There's no form to fill out. Is POCUS in resuscitation has been associated with A, improved mortality, B, no mortality benefit, C, worsened mortality, D, all of the above, or E, none of the above. And just want to everyone plug in your answer for the talk and just think about your answer, what you would answer for that based on what we've seen so far in the literature. Overall, as a talk, we're going to start with looking at shock as an entity, a little bit of just backgrounding to provide basis for the rest of the discussion. Some of the aspects of monitoring shock and the issues of echocardiography and looking at it, some of the evidence on POCUS and looking at shock and as it's been practiced in both the emergency and the critical care worlds, and then we'll just look at a few cases. So we've always looked at trying to figure out how to manage shock and resuscitation and by tailoring therapy. And of course, this is from the ACCM shock guidelines in terms of our traditional approaches in working through initial fluid resuscitation and then tailoring therapy based on the phenotyping of shock that we'll do through our various interventions and assessment measures. And over time, we've gotten more and more into the idea with the phenotyping of trying to identify the specific issues that might help us figure out what best to do is therapy, in terms of identifying, first off, cardiogenic shock and anatomic and potentially other electrophysiologic causes as things that could throw a wrench into our traditional management, and how do we integrate some of that additional data into getting our patients to exactly the therapy they need as quickly as possible. And the specific cardiac issues sometimes are put to the side as we try to focus and make our algorithm to respond to shock as reproducible as possible. And there's the persistent questions as to whether or not echocardiography could help with that. There's also issues with neurogenic shock that might require a different approach to things, as well as toxic and metabolic shock and specific toxicology remedies that would make the picture for the initial resuscitation a little bit more challenging in those specific realms that have led us to calling consultants earlier and earlier. And sometimes the key question is do we have that already in mind by the time we're asking for help? And of course, there's also the arena of trauma, which oftentimes we're less in the dark as to why the patient is having trouble, but we may need help early on in terms of figuring out when to activate resource heavy therapies such as massive transfusion protocols or surgical remedies. The overall profiles that we have traditionally moved shock into have been the using the ACCM guidelines have been in looking at the patients with compensated low cardiac output, uncompensated low cardiac output, and then uncompensated high cardiac output. And this helps us to form a general framework for our approaches. Looking at categories of shock, we've known this from med school. I'm not going to go through all the little arrows and things, but this has also been an area that we've branched into, especially with POCUS, to try to help protocolize what our responses are to therapy in terms of identifying and distinguishing hypovolemic from cardiogenic, from vasoplegic, from obstructive, from dissociative shock. And in the heart failure realm, we also subcategorize shock into dry and wet and warm and cold. But ultimately, I want to challenge this in asking: is a compartmentalized strategy valid? Is it always helpful to box someone into one of these quintiles or one of these quadrants? And as we've gone away from the PA catheter in general practice, though we've kept it in our interventional cardiology realm as a way to profile patients, we often see mixed causes for why someone is in shock. And the analogy I like to say is that it's kind of like a kid's ice cream party. Within about an hour after it starts, everything slowly becomes the same flavor as acidosis affects vascular tone and cardiac function. And with ongoing therapies, we also have factors that we introduce that may influence our bedside hemodynamics, including the potential for fluid overload and airway pressure effects on the right heart. So looking at things that would help us along this road, of course, in CV monitoring, we'd be looking for desirable qualities of having, of course, validity, being able to trust what you're looking at, making sure that's accurate and comprehensive. Additional benefits would be either continuity or serial exams to be able to help titrate our therapies, and then the intervention itself being safe and non-invasive and accessible. And we can begin to see how ultrasound may be able to assist us in any number of these ways. In terms of validity, we don't know for sure as to all of the aspects of how POCUS might help us, but part of that is just because we are still figuring it all out in terms of how we can best apply our imaging modalities to resuscitation, and the literature is growing. Serial exams are easy. There's even been talk about some level of continuous examination in limited settings. An example being in not so much for shock, but transcranial Doppler has been used in continuous monitoring situations where a TCD probe is held in position and you can monitor waveform changes over time. Who's to say that there wouldn't be a place for that in bedside monitoring? And there's always this ongoing question as to when we might be able to see something like that. Ultrasound is pretty non-toxic and non-invasive in most settings. And it's pretty much in every academic unit now, with very few exceptions. It's been applied in a couple different paradigms, and the table at the bottom left is an example of just that with the explosion of POCUS, people have tried to put it into a lot of different protocols in approaching assessing the decompensating patient. Now, not all of these are straight shock. Some of them are trauma protocols. Some of them are sepsis protocols. Some of them are emergency resuscitation protocols. But we sometimes call them the train of four-letter words that ultimately amount to a pretty similar approach to how people look at things. Usually, like the example on the right, the FADE exam, we're looking at about 5 views, including the 4 major views of the IVC. The 4 major views of the heart and plus the IVC, and then there's the plus-minus addition of pleural scanning, where folks end up using an overall gestalt from multiple serial images to look at cardiac performance, and then to try to characterize what in general from this series of images is the overwhelming prevailing diagnosis. And there have been papers that have reflected the impact of these findings. When you've got, resuscitation in progress, you put the probe on, you get pictures, and the impression that it gives you, how does that impression influence what you're doing at the bedside? And in a prospective study that was published recently in Peds Emergency Care in 2021, 35 patients who had received 80 imaging studies. Part of this, of course, was serial imaging during the course of their resuscitation. It changed their diagnosis in half the patients and changed management as such. In a study in the ICU back in 2014, Ranjit et al. Published a prospective observational cohort study examining 48 patients where intensivist performed echo influence titration in 87.5% of patients, resulting in shock resolution in 96%, with 91.6% of the patients surviving to discharge. But the thing to think about with papers such as these, and there are many in the literature, they didn't necessarily compare anything to control. These were cohort observational studies that profiled the overall clinician behavior, and it just describes that it impacted behavior in general. The team at CHOP in 2021 published a trial looking at how does a protocolized hemodynamic assessment align with the phenotyping of shock based on a institution-wide resuscitation protocol. And so this is a retrospective observational case control study looking at 71 patients under the age of 18 who had suspected septic shock and were triaged by shock category. And what was examined was whether the POCUS examination demonstrated concordance with the septic shock pathway designation that they had from the institutional work. And with this, they overall had good alignment with some of the major targets that POCUS has historically been good at, particularly cardiogenic shock. Hypovolemic shock was a little bit tougher, as was vasoplegic shock, and obstructive shock going along with a syndrome where you're looking at either like left heart obstruction or right heart obstruction, in particular in this protocol, leading to direct cardiac changes was also overall a better correlation. And overall, with algorithm direction, management was aligned between the two in 75% within 4 hours. I think this paper highlights the practicality or the impetus of what POCUS is meant to do in helping with assessing shock. It also focuses down on the issue of that, when shock is, of course, more than just the heart. And a lot of POCUS is the heart. So how are we integrating the information in a way that puts the whole picture together for the resuscitation of the patient? And it's a good point in the talk to just highlight that the overall course of using POCUS is one where maybe we should be looking at not so much that it is the machine has come to save us from the Deus Ex Machina, where the machine is gonna rescue the patient. It's that it integrates into the battery of things that we have at the bedside to help us focus our care, provide additional evidence that helps us get to the finish line with the patients. A very interesting paper was published by El Nawawi in 2018 in the Journal of Pediatrics from Brazil, which looked at the role of echocardiography in reducing shock reversal time in pediatric septic shock, and this was an RCT. It involved 90 patients between 1 month and 11 years who were initially admitted with septic shock. It excluded those with cardiomyopathy and known congenital heart disease. And it was a single observer trial, and it, in terms of suffering some of the vulnerabilities of this type of study, where you only have one person who's echoing and helping to basically determine management. But myocardial function and IVC diameter for fluid status were the only metrics that were measured, and LV shortening fraction and diastolic function were used to titrate dobutamine and melanine. And it found overall very enticing results in terms of faster reversal of shock, the faster success or better success in reversing shock, shortened length of stay, and also an overall mortality benefit. And so this was pretty declarative in terms of what the authors thought was going on, and the major caveats were just that the things that we mentioned before, that it was one observer, single center, and they were evaluating diastolic dysfunction as a intervention. In the adult world, there's also been more and more evidence that things are moving in the direction of like being able to find a positive signal in how POCUS might improve resuscitation. JENTZER et al. Is one of the cardiac ICU folks in the adult unit at Mayo in Minnesota, who within that group has published a lot of really interesting papers about how echo-guided resuscitation early on in the adult cardiac unit has perhaps some level of mortality benefit amongst the patients presenting primarily with cardiogenic shock. So again, we're talking about adults. We're talking about patients who might have a very cardiac specific reason for why they're presenting. This is a retrospective case control study in 1,085 adult CICU patients who had echo by day 1 of admission. But the authors themselves were cardiac intensivists who were cardiologists at Mayo. But it was described by themselves as cardiac POCUS, as probably the workflow where they're putting the probe on at the bedside while they're resuscitating the patient and figuring out what's going on, rather than trying to get a full diagnostic study. The indices that they looked for were indices of filling and function. Patients who died had a lower median EF that was statistically and probably clinically evident. And the best predictor they found for overall survival was having an LVOT VTI, or basically a surrogate for stroke volume that we'll talk about in our later talks, of greater than 13.2 centimeters. They use adult, in the adult world, they use, they're able to use adult absolute measures for overall VTI to tell you like how well the LV is ejecting across in systole. And overall, the profile on the right were the classifications of the types of cardiogenic shock that the patients were having, and how patients who had elevated filling pressures tended to have the various tended to have the identified pathology that's marked on the bars. So not everything is rosy. Shock ED was a major study that was done in 2018. It was this is probably the largest prospective trial that was also randomized, looking at the implementation of POCUS in the resuscitation of patients presenting in shock to the ED. The investigators trained people to be able to operate in terms of abdominal, lung, and cardiac POCUS, which is performed within 60 minutes of admission. Ultimately, this was a study that did not demonstrate positive results, and there was no effect on 30-day or hospital discharge survival, fluids or inotropes administered, or admission rates. And it was ultimately terminated for futility, with the original target being around 400 patients. They performed follow-up studies examining shock types and undifferentiated hypotension. There was no change demonstrated, and the only thing, sorry about that. The only thing that was somewhat of a discussion topic was that it lengthened resuscitation, cardiac arrest. This was in a time where I believe that not all the cardiac arrest POCUS that was done in these centers was protocolized to the same protocol. And just recently, in the past year, in the Canadian Journal of EM, Peach et al. did a review of the data follow-up of the patients, and looked at 270 medical records of the 273, and found that overall the diagnostic performance of POCUS in these cases was similar to non-POCUS. And so the question really comes up as to whether or not POCUS is telling us what we know already when we're looking at a sick patient at the bedside, and integrating everything into the pool of data that we have at the bedside. Is that necessarily a surprising result? The questions as to whether or not shock ED was a study that was ultimately helpful, it came back to the fundamental question of like, have we all figured out what we're doing? Have we all figured out how do these individual tests integrate into a functional exam, or are we just getting a bunch of nice pictures? And so that question has persisted, and folks have been looking at ongoing prospective work trying to narrow that down in not just making these protocols about getting the pictures to look like what you see in the textbook, but to be able to apply the data that you're looking at the pictures in a reproducible manner to influence care. And that's one of the things that still remains on our docket. And there's a reason to be looking at this with some sort of time pressingness to it, and that this paper came out soon after in 2019 by Moser et al. In Critical Care Explorations. This was the most accessed paper that year in Critical Care Explorations. The SCCM's open access publication. It was impact of point of care ultrasound in the emergency department on care processes and outcomes in critically ill non-traumatic patients. It was done as a retrospective case control. What they did was they basically opened up their PACS system for POCUS, and they looked at all of their cases and divided them by mortality. And they looked at 5,441 adult EM patients presenting with non-traumatic shock. 4,165 did not receive POCUS. 614 did before therapies were initiated. 662 did after therapies were initiated. And then what they published that was very interesting was that POCUS prior to the resuscitation intervention was associated with mortality odds ratio of, or hazard ratio of 1.41. And it was statistically significant. And so these are the things that keep some of us who teach POCUS up at night. It's like, are we doing something that is actually hurting people? And the discussion got more and more interesting. So Vedette, who's also on this call, lead authored our letter to the editor that approached Critical Care Explorations and Dr. Moser and asked about, well, what do you think about the non-random use of POCUS? The fact that oftentimes the ultrasound machine gets dragged into the room with the sickest patients. And the thing that was not answered at all in Moser et al. Was whether or not the data included procedural POCUS. Are you guys getting are you guys counting the vascular access exams where you're putting a central line in the patient? And are we just showing that the more devices you have in a patient, the more likely they're going to die? The thing is, we had that accepted, and then immediately after, in the next month, their peers had their letter to the editor accepted, which had been accepted prior to ours, and there was that whole like acceptance publication gap that threw us all off. But Amini et al. Said, guys, you took all the studies out of the PACS system, including all the educational studies, and if we have that disparity in terms of looking at these patients, then we really have a situation where we're just counting studies as opposed to really determining whether or not POCUS in itself led to any deviations from care. And one could argue the same thing. It's like, the propensity for mortality is you'd have statistically higher number of pumps in the room. You'd have a statistically higher number of medical student consultants in the room. Is that the reason why these patients died? And of course, that doesn't hold water. So the thing is, like, we are still figuring this out a little bit. There's something that we should still be looking at in terms of quality and whether or not we have an effect on care by doing POCUS. But right now, the literature hasn't necessarily quite proven that, but the literature is primed for that. Like for a Connors type paper, that the paper that ended up really being a part of the downfall of the SWAN in its use in patients. And to be fair, the SWAN was used in a lot of patients. It was used in a lot of patients that might not have needed a SWAN, but at the same time, we have seen it go away from a lot of our units. It's a pariah in many ICUs, not all of them, but yet we get the numbers from the cath lab as if they're golden. as if they speak, unquestionable truths. And so with that disparity, is implementation a factor? Is it not just, whether or not we're looking at it in a non-protocolized way? Is it that we need to be providing a little bit more guidance, a little bit more standardization, a little bit more outcomes data that is very targeted in terms of the patients that we're testing it in and the outcomes we're looking for, to be able to hone this down and make it work? And is this important? As we probably said before, one of the factors is just that POCUS is part of the boards for all of the major inpatient, urgent and critical care specialties. It's on the boards for all of the critical care specialties except us, and NICU. We're talking about adult SICU from the anesthesia and the surgical side. We're talking about neurocritical care. In all of these domains, you have to be able to look at the heart to be a neurocritical care doc. Of course, in the realm of emergency medicine, it's all across the board for adult and peds. And for neonatology, even though it hasn't yet gotten onto their boards, it is on their U.S. News and World Report survey to have a POCUS program. And so as we hone this and make it a part of our routine practice, it's probably in our best interest to try to figure out best thresholds for using it and integrating it. And even if we don't find that it leads to different conclusions, sometimes the fact that it could help solidify a case of a difficult to parse shock may be meaningful. So in this realm, the SHAIP paper on the left, from Critical Care Research Papers back in 2012 is a table also from that same paper where we had all of those protocols listed: ACEs, BLEEP, FATE, FAST, and so forth. And the authors were proposing the use of the RUSH protocol, which is it's a very popular EM resuscitation protocol that looks at conceptualizing the circulatory system as a pump, a tank, and a pipe, and then to try to use that schema in your head to then integrate all the images that you've obtained into the overall resuscitation. It ends up being a little bit complicated, as you can see from the chart, and it also is one of those things where we have to be able to also accommodate the patient who's got a mixed shock picture. So it's something that is used a lot, but it's very hard to standardize. And then other protocols can be as simple as the one shown by Park et al. In Peds Emergency Care back in 2015, where we have a almost like a 3-question test as to whether or not you're squeezing okay, whether or not your fluid status is okay, and then whether or not your lungs are okay. So maybe more along the lines of like, what do I do right now? But phenotyping, it can get pretty exotic, as we saw before from looking at like neuro, cardiac, and toxicological causes. And then Youssef et al. In European Journal of Pediatrics in 2019 proposed a model in the neonatal unit that has quite a few decision-making points and branches into quite a few decision points to try to figure out where you're going with your overall resuscitation. And in terms of practicality, you, of course, would have to have this chart in front of you as you're treating someone. So, just a little bit of a brief recap. Existing protocols emphasize qualitative imaging. We really don't have much in the way of clinical thresholds, though we've tried. We've tried to give ourselves numbers for IVC collapsibility, for measures of ejection fraction that might help us with myocardial performance. The questions that persist is what we're seeing, what we think it is, which is something that I think we've been looking at in terms of some of the evidence that's been already published, and what are meaningful measures and decision points. So some of it goes back to the nature of echo on its own, and going to like what is what we're seeing, what we think we're seeing. Fei Williams back in 2019 in Journal of Intensive Care Medicine published this paper looking at echo reports in terms of characterization of myocardial dysfunction in fluid and catecholamian refractory pediatric septic shock and its clinical significance. It was a retrospective case control looking at 78 PICU patients with septic shock who were echoed 24 hours after sepsis was diagnosed. Myocardial dysfunction was prominent in this population and related to severity of illness, but ultimately not associated with mortality. This is one of the things about echo is just that, you know, not everything that has bad function is the same diagnosis. And I know that that is a little bit of a no-brainer, but let's just kind of like look at the scope of everything for a moment here. Of course, we've got, you know, our PICU standby of myocarditis and sometimes dilated cardiomyopathy on the left, demonstrating poor LV function and a dilated left atrium, like LV here, mitral valve in the middle and the left atrium below it. We can have an arrhythmogenic cardiomyopathy where we have a worn out heart that, you know, after this instance of a flutter was cardioverted, and then our LV is just not contracting as well, and because it's been a little bit stressed out. We can have stress cardiomyopathy with Takotsubo's-like picture where we have a patient who had status epilepticus, and we still have some basilar preservation of contraction, but the apex is not as contractile, you know, classic to that phenotype. And then we can also have issues of like toxicologic cardiomyopathy, where we might have just taken a ton of propranolol or metoprolol. We can have post-arrest myocardial dysfunction, where we've had, you know, all the stressors of a cardiac arrest situation also were out the heart, we're filled with boluses of fluid and peripheral vasopressors that might be influencing function. And then also, just one of the most common reasons why we have reduced squeeze, we can have hypertension. And so this patient was a renal patient with pressures of 160/100, and we have a heart with relatively normal function trying to squeeze against that increased afterload. And all these generate, you know, the picture of a heart that's not squeezing it as well, but not every one of them need epi. And as we go into the anatomic realm, aortic stenosis as an outflow obstruction issue, causing reduced LV contraction, aortic insufficiency, causing overload of the heart and reduced ability to contract, and extracardiac left-to-right shunt as in a unrepaired PDA as another reason to have increased preload and decreased squeeze. All of which raise the question of, like, you know, is one therapy for one finding necessarily the right way to go? And granted, a lot of what we see in the PICU is shock from sepsis. A lot of the times, many, you know, it's probably the right answer in a whole lot of times, but it's not always the right answer. The IVC has been problematic as well. There's been 3 meta-analyses in adults that demonstrate no association between IVC collapse and fluid responsiveness or CVP. This has been shown to be related to quite a few factors related to its measurement. It is such a popular POCUS measure. The downfall to it has been trying to put it into context in the care of our very heterogeneous patient population. We know that when you inflate the airway, as was done in the study in the bottom right, Elena Lin is this great pediatric anesthesiologist at CHOP. She and her husband, Aaron Chen, and Erikira Nishisaki and Thomas Conlon worked on a paper looking at whether or not you take someone who's healthy in the outpatient setting, coming in for elective surgery, gets intubated, and that institution of airway pressure, what does that do to your IVC performance and being able to reflect your overall fluid status? And really all it takes is intubating and putting them on some level of positive pressure ventilation. And we're talking about PEEP of 0 to 5, PIP of 15 to 25. And immediately IVC respiratory variation goes down. When you take away someone's spontaneous breathing, then your variability goes down, and, you know, and vice versa. And we know that, you know, that the patient on an oscillator or who has other forms of increased airway pressure, from bad asthma or COPD. Those can all influence, those can all influence your appearance of your IVC in ways that you may not be anticipating. And we know that in the normal pediatric population, the random kid who comes in to the echo lab to get a structural echo because maybe they had they had a murmur in the outpatient setting that needs to be evaluated, or they might have had an EKG that demonstrated some findings that needed to be checked. In those kids, your normal IVC collapsibility is 30% with spontaneous breathing. But the thresholds for fluid resuscitation in mechanically ventilated adult patients is 15%. So it seems the thing is, like, in the natural state, we live in the fluid resuscitation realm. And for these reasons, we need to perfect our fluid resuscitation approaches. One thing that I wonder is just that, we focus a lot on IVC and CVP, which are predominantly right heart measures in terms of the intervention of fluid. But instead, if we think about, as I do often in the postoperative setting, what do I need to do to treat this patient that is presenting in, postoperative slump, a little shocky? Do we pull off too much fluid? Is the heart just not squeezing as well? I'm predominantly looking at the LV and how it's ejecting across the LVOT to help parse out whether or not a fluid responsiveness issue, and whether or not it's because they're hypovolemic, or because maybe the right heart isn't moving blood over as well as I'd like it to into the left heart, or we have some vasoplegic issues. All of those things would be things that I'd be thinking about, like, some sort of like gentle to not so gentle fluid resuscitation, depending on the situation. And what I'm looking for is how well I'm squeezing across out of the left heart, not so much what's going on the right heart. And I wonder if there's something to be said for focusing our fluid resuscitation stuff on that, not so much looking at, am I treating hypovolemia, or as opposed to, I'm treating a situation where it's safe to give fluid relatively, and what do I need and how do I approach that? So maybe not looking for strict hypovolemia, but rather, like I said before, like distributed shock, that was eventually going to need vasopressors, but you might need to get some fluid in quickly, or RV dysfunction that might be responsive to some additional fluid resuscitation. And I think it really highlights what POCUS is about when we talk about just structural findings that can help us along. So effusions, we know it's really good for finding effusions. We know that peds intensivists in this case series done with Spurny et al. Published in JACE, almost coming up on 18 years now, demonstrated that peds intensivists with a machine that was 1 or 2 generations back could find 96% concordance on function and size with imaging that was evaluated by sonographers, and with the concordance of 91% on pericardial effusion with cardiologists. And Mindy Longjohn in 2011 looked at echocardiography by peds EM docs and found pretty similar results in terms of the overall performance in looking at 2D imaging and how it helped narrow diagnoses. So the algorithm we try to teach here is the serial hemodynamic assessment in pediatrics. We tried to make it kind of APGAR-like, in that it focuses down to squeeze, hypovolemia, anatomy, intraventricular septum, and pericardial effusions as targets you want to hit on your exam. And the overall protocol is to, first you start off with shock identified, you make sure it's safe to do it. You decide to do an echo, make sure that you've got what you need. You look for an effusion. And this really helps, as one of the first things you check, because sometimes you see the huge RV or something like that, and you get a little distracted. If you see an effusion that's symptomatic, that leads you down a pathway there. If you have an absent effusion situation, or you've already identified that and you're moving on, you use your LV and your RV squeeze to try to phenotype whether or not you have like a primary RV or LV dysfunction or an obstruction to outflow. These things would just be check marks that you'd have in your head to be looking at next steps. And then you can test your fluid responsiveness by looking at your overall loading on your LV. You can use your other clinical markers, your best clinical judgment. You can push on the liver, raise the legs, and the fluid responsiveness will help you further parse out whether or not that patient, now that you're thinking, well, the squeeze is okay, I'm going to be looking at fluid now. It help you figure out, you know, your overall algorithm in approaching those patients. And as you steer more and more right on this tree, it's a situation where you know you're favoring fluid than vasopressors. As you steer more and more left on this tree, then you're considering mechanism, inotropes, and whether or not afterload management is something that is safe and needed. And of course, a branch point that's necessary in any kind of protocol is looking for help. And so if there is something about the anatomy, something about the position of the intraventricular septum that seems pretty dramatic in terms of, like, you know, the critical RV failure, then to be sure that, you know, either at the start or some point during resuscitation, to look at escalating your evaluation, calling in help from cardiology, surgery, radiology, and so forth. And so the thought here is to use ultrasound not so much as guidelines for figuring out what you're doing, because you're clearly integrating your whole exam in the course of the patient, but as guardrails as opposed to guidelines. And so, you know, it's looking at that patient, looking for bad function in the kid you're about to bolus, 20 per kilo saline into, and saying, oh, wait, there is something wrong here. For, say, maybe that, you know, that like 6-year-old who comes in with 2 weeks of URI, looks kind of gray, has been vomiting and having diarrhea, and lo and behold, actually has a cardiomyopathy. And it's just to bring back the topic of, like, you know, with all this, like, when do we ever use one monitor to guide all therapy? So the hope is here is to integrate POCUS into a comprehensive exam but make it something more lean and something more reproducible to be able to really see what its effect is on care. So we come back to the question: POCUS and resuscitation has been associated with A, improved mortality, B, no mortality benefit, C, worsened mortality, or D, all of the above. And the answer is D, all of the above, because we are still working this out. We're trying to figure out what we're doing with this, and banking a bit of this on the applications that we've seen where it seems to be helping us get to our decision making in conjunction with everything else. And so that may be a benefit that we have. It's also very, very hard to study. So trying to figure that out. So I just want to run through a few cases real quick. This is one that I use a lot just because it's I thought is just really interesting and illustrative. So it's a 6-year-old with ALL who was admitted to inpatient floor. We had recent fever, neutropenia with E. coli urosepsis, was on the mend, got pegosparaginase as a part of chemo management. Patient became profoundly hypotensive with an altered level of consciousness. Rapid response was called. Patient was emergently transferred to the ICU, was bolused for a heart rate of 180, blood pressure 50s over 30s, with no improvement. So was getting fluid unresponsive shock. In the ICU, patient was intubated emergently. Patient went to PEA with tachycardic sinus rhythm at 180. So, you know, of course, on the differential for this patient, we have chemo-induced cardiomyopathy, the potential for sepsis, the potential for distributive shock as a result, or hypovolemic shock as a part of that as well. And we put the probe on, we saw marked hypovolemia. Like this is the liver's up here, diaphragm and inferior pericardium. The right-sided structures are against that. So the RV and the RA are right below that, and below the ventricle is the LV, and you can see the LV as the muscular circular chamber to the bottom right of the picture. The cavity ejects nearly completely with every systole. And we continue to resuscitate and push volume. You can see the RV, like right above the LV, start to fill in a little bit more. And then we can see the IVC here with this dark line going from the upper left towards the right of the screen into the inferior cabulature junction into the RA, still kind of flat and squishy, getting a bolus with the bright fireflies of the bolus coming up. And so sometimes people wonder if this is air. It's the density difference between the saline and the blood that's generating an echo, and can sometimes be helpful in trying to identify whether or not your central line is in a venous position. But this was active resuscitation. So quote unquote fluid unresponsive shock, but actually was needing a lot more. And we were pushing like 160 to 180 cc's per kilo to get the kiddo resuscitated. And ultimately kid came off of epi, which had already been ordered within a few hours, and was hemodynamically stable that evening, and then was extubated in a day or two, and then was back to the floor with no neurologic consequences in about 3 days. And so this kid could have been quite a number of things, ultimately being fluid responsive shock that just needed like a ton of fluid to respond to it. And so ultimately a POCUS helped us get the care that they needed in a more profiled way. Case 2 is a 6-year-old female with refractory ALL. Patient received clofarabine, became progressively more hypotensive and tachycardic. Heart rate of 140, respirators of 26, 70s over 30s, satting 100% on 2 liters nasal cannula. She was a patient who had been admitted for chemo protocol and was was receiving an escalation in care with clofarabine. And the thing is that you see it used less and less in the IC in the patient population that ends up in the ICU, partly because they use more steroids with it, partly because it causes a lot of third spacing. And so the patient was in shock. Could it be effusion, hypovolemia, chemotherapy-induced cardiomyopathy as all possibilities in the patient profile? And kind of given away the answer already. This is a subcostal view. Again, we're looking at from below the xiphoid process at the heart. Here's the liver, here's the diaphragm and the inferior pericardium, and then we see a big old concentric effusion. The view on the right is a sagittal view of the IVC. This is a little bit farther down the liver than the last view we saw. The thing to highlight here is that when you have a patient with tamponade, as was the case with this patient, you will have a dilated IVC. It's one of the most sensitive measures of a tamponade physiology. It's one of the first things to happen as you have this obstructive shock. Your venous system starts to fill in, which then brings you back to that question, well, if you have a full IVC, should you be bolusing fluid? And the little fireflies shooting up the IVC here would suggest yes. POCUS, we're now looking for it to change known management. When you have a tamponade, you bolus fluid to try to fill in the compressed heart. And it's one of the instances where it's like, you're not using the IVC to figure out whether or not you should be giving fluid or not. So ultimately, patient got a pericardial drain, was sick with capillary leak for a few days, slowly improved, drain was removed, and then transferred back to the inpatient unit. So case 3 is actually what I put in here as this being pretty classic as to what we see. So aside from the COVID now, thankfully. So a 16-year-old female, previously well, COVID PUI, suspected MISC, vomiting, watery diarrhea, mild URI symptoms, heart rate of 110, pressures of 70s over 30s after getting 2 liters of 2 liters of normal saline, and satting 100%. Has a right IJ CVL in place with CVP of 5, was alert but tired, appearing with cap refill of 3. So we scan, IVC is a little bit collapsible here. And then we have just the mildest amount or low normal cardiac function. And the reason I put this up is that this is most of the kids you're going to see. You're going to have a IVC that looks like it can still accept fluid, and you're going to have a little bit of cardiac dysfunction, and the kid's going to be a little bit hypotensive, and we have to figure out what to do. So again, this goes back to, just to put it together there, this goes back to the idea of using ultrasound as guardrails as opposed to guidelines. And so we already have low CVP, blood pressure, or low normal CVP. We've already resolved to try to continue to give this kid fluid, and we do it, and with the idea of like, it's also time to start pressors. And so with this, then the answer was that we did both pressors, and we did both inotropes and fluid. And the idea here again is like chalk is not monolithic. It's like that ice cream party. Ultrasound may sometimes give conflicting findings or more of a mixed picture, and we use it to inform our decisions to help us keep our therapies in line. So we can give fluid when there's less evidence of overload. We can start inotropes in the absence of hyperdynamic function. Like, you know, if it was the first kid who had an LV that kept on ejecting completely with every systole, epi probably wouldn't have been the best answer. So patient responded to fluid. We started epi anyway, but was rapidly weaned off. Patient was COVID negative, was influenza positive, improved in 2 days, and was transferred to the inpatient unit. And it's just I keep on saying it, but yeah, not all depressed function equals epi. And the last one we'll do is a 10-year-old male pedestrian struck by a motor vehicle, stable pelvic fracture, bilateral lower extremity fractures. Patient initially alert and pain, was sedated for reduction with ketamine and midazolam, now somnolent. Heart rate of 160, respirators of 28, BP 70s over 30s, setting 100% on 2 liters nasal cannula. And so patient in shock. Could it be trauma itself? Could be that, you know, we're reducing the fractures and it's myocardial effective sedation or the vasoplegic effective sedation. And so looking in parasternal views, if we put the probe right to the left of the sternum and look as a cross-section across the LV on this image on the left side, we look at the circle of the LV, and it completely collapses with systole. The RV is the little delta to the left of the ventricle on this image. And then we also see a little bit of a pericardial effusion. And then this is a personal long axis view that was taken a little bit low. That's why we're so close to the apex. We rotate the probe 90 degrees and we kind of look at the lower part of the LV here. And both of them are showing that, yeah, we have a LV that's squeezing out a decent amount of its stroke volume with every contraction. So it could be the sedated picture of the kid who got sedation. You're wondering if it's a sedation effect, but it's actually some of the effects of trauma. This is just another example in short axis of an LV that's completely collapsing. This is an IVC that's collapsing pretty briskly as well. So this was a kid with probably a little bit of an unrecognized loss of blood into the long bone and pelvic fractures. If we put the Doppler across the LVOT, where we are looking at the outflow tract of the aorta, and we're just trying to Doppler its overall flow. Each one of these little triangles with a dark center is a stroke volume coming out of the LVOT, and we can see a little bit of variability with them, probably greater than 15%. And on the A-line tracing, if this kid had an A-line at the time, we would see the same thing. So we'd have a non-invasive way to look at stroke volume variation over the respiratory cycle, suggestive of hypovolemia. Yeah, thanks for that. Yep. And so overall, the patient was hypovolemic. The sedation kind of unmasked it a little bit, and we ended up going in a different direction in terms of overall care. Yeah. So ultrasound is established for cardiac assessment, as it is in nearly every ICU. Attention is spent on imaging skill, and that's a good thing, because as we get better images, we have a better impression of what we're doing, but we need to focus on implementation. And we know that it can help as a non-invasive serial bedside assessment. I think its ongoing implementation should focus on safe coexistence with existing resuscitation strategies, with it, not necessarily the intent to replace anything. And it is something where we're still trying to resolve the questions of, like, is it like the monolith in 2001? Is it the thing that's come here to save us from undifferentiated shock, versus the question of is it the emperor with no clothes? And we still have to figure this out a little bit, but I'm hoping that some of the cases at the end of the talk help illustrate why we're still trying to figure it out. We might have something that could really help us with getting our patients to resuscitation a lot faster. And that's it.